Hello, everybody. My name is Sebastian Santolano, and in the next minutes, I'll take you through a very important and timely topic lung injury in patients with SARS CoV 2, also referred to as COVID 19. I'm doing my PhD in the field of AI based diagnosis in radiology and found this a relevant and timely topic to address. In my presentation, I will describe some key features of lung injury during COVID 19, including pathogenesis, clinical symptoms, imaging findings, and treatment. And I will also compare this with other coronavirus infections. Furthermore, I will discuss imaging methods with special attention for artificial intelligence in assessing the extent and severity of pulmonary fibrosis. So, when we look at the difference between regular flu, COVID 19, which is caused by the new SARS CoV 2 virus, SARS, which is also known as SARS CoV 1, and MERS, we see that SARS CoV 1 and MERS typically have a higher hospitalization rate and case fatality rate. The R0, which is the reproductive number, is defined as the number of patients that one patient under normal conditions can transmit the virus to in a population with no immunized patients. This number is also higher for SARS-CoV-1 than other coronaviruses. So then why is COVID-19 so dangerous? Well, normally when people have symptoms, they stay at home and other individuals keep away from them. But with the new SARS-CoV-2 virus, there is a long asymptomatic period when patients are infected and have a high viral load. So let's have a quick look at the clinical and imaging findings of SARS-CoV-2, SARS, and MERS in this review in the American Journal of Röntgenology by Melina Hosseini. The three diseases share similar clinical features, though gastrointestinal symptoms seem to be less common in COVID-19 than SARS and MERS. Also, sore throat seems to be less common in COVID-19. So when we look at the imaging findings in the same study between COVID-19, SARS, and MERS, these are highly similar in the acute phase. Approximately 20% have a normal CT scan, and furthermore, peripheral multifocal opacities, both ground glass opacities as well as consolidations, are seen, usually not superimposed on chest X-ray and CT scan. Nevertheless, in the follow-up imaging, there are some differences, including that there are more signs of pleural effusion in MERS, which are less reported in SARS-CoV-1 and SARS-CoV-2. So when we look at this 919 patient systematic review on common patterns in COVID-19, we see that initially ground glass opacification occurs in more than 88% of the cases, bilateral involvement in also 88% of the cases. There is a more posterior distribution, a multilobular involvement, and a peripheral distribution in more than 2/3 of the cases. So before going into some clinical CT cases, let's first look at CT findings of pulmonary injury following ARDS. As you might know, ARDS stands for acute respiratory distress syndrome, and in SARS is a type of acute diffuse inflammatory lung injury marked by increased alveolar capillary membrane permeability, edema, loss of aerated lung tissue, increased work of breathing, and impaired gas exchange. According to its Berlin criteria, this ARDS is defined as hypoxemia and of bilateral chest opacities within 1 week of a known risk factor. Another condition is that respiratory failure is not fully explained by cardiac failure or fluid overload. So again, ARDS is defined as hypoxemia and bilateral chest opacities within 1 week of a known risk factor. Then if we look at hypoxemia, this is defined as an arterial oxygen tension divided by an inspiratory oxygen fraction ratio of less than 200 millimeter mercury pressure. So inspiratory oxygen fraction is actually the volumetric fraction of oxygen in an inhaled gas. There are three phases of pulmonary injury following ARDS that can be distinguished. In the first week after onset of symptoms, this is the acute phase. In the second week, the intermediate or proliferative phase. In the late or fibrotic phase. This occurs after 2 weeks after initial onset of symptoms. So I guess this is a very important slide, and I'll go slowly through it. In the acute or exudative phase, in the first week, usually in the first 2 days, the CT is normal. Thereafter, in the next 2-3 days, there is a rapid deterioration with increasing bilateral patchy alveolar opacities progressing to diffuse consolidations. Usually, lung volumes are reduced and air bronchograms are visible. A diffuse, so-called crazy paving appearance has been documented. This is a reticular pattern superimposed on ground glass opacities. In the reticular patterns, as you might know, there are too many lines, either as a result of thickening of the interlobular septa or as a result of fibrosis, as in honeycombing, which we will see are more the sign of the late fibrotic phase. In the intermediate or proliferative phase in the second week, the radiological findings are rather stable. Reticular opacities may appear in the diffuse and persisting background of alveolar opacities. Coarse reticulations are not a reliable sign of fibrosis because they can substantially resolve. In this phase, the extent of CT opacities, if more than 80% of the lung volume, along with the presence of bronchiectasis, honeycombing, and signs of pulmonary hypertension, indicates early fibrosis and highly predicts mortality. In the late or fibrotic phase, 2 weeks after initial onset of symptoms, more than 70% of the patients present with CT abnormalities at 6 months follow-up. In the later stages, persistent ground glass densities and reticulations are seen on CT. Air cysts and bullae, mainly located in the ventral regions of the lung. More severe fibrosis has been reported in patients with pulmonary ARDS and prolonged mechanical ventilation with high positive end expiratory pressure, or PEEP. In the next slides, we will illustrate some case reports from China that have been shared on Kaggle. Have a look and try to see whether you can detect any of the previously mentioned signs. In this clinical Kaggle case, CT images reveal characteristic white ground glass patches, shown here by the arrow, which represent interstitial fluid collections. In this case, we see the first ground glass opacities peripheral in the right upper lobe. Notice there are bilateral and skip other lung areas. Furthermore, you can see an air bronchogram sign here around both hilar regions. Furthermore, in the right lower lobe, you can see a consolidation. Is this pneumonia or is this potential fibrosis? In this second Kaggle case, we see in the left lower lobe an area of diffuse peripheral consolidation, here shown by the arrow, without cavitation and less the ground glass opacity component. This Lancet CT study of 81 patients from Wuhan, China, describes major radiological findings. Notice here that a p-value of less than 0.05 means there is a significant difference between the subgroups, for instance, between unilateral versus bilateral lung involvement. In red, you see the predominant findings in this 81 patient cohort. This is still preliminary data, and the authors rightfully conclude that it is too early to label lung changes as irreversible fibrosis. So as we see, there is a predominant significant bilateral lung involvement, predominantly peripheral, non-significantly random or subpleural more often, significantly diffuse, and significantly higher ground glass opacity pattern. Let's move on to the next slide. So why does severe pulmonary damage occur? When SARS-CoV-2 enters the alveoli, it attracts immune cells. In early stages, depicted on the left side of the graph, alveolar macrophages are attracted, which activate T cells. In later stages, neutrophils and monocytes are attracted. Activated T cells release interleukin-6, which is a cytokine which triggers additional T cells to be made, which then release even more cytokines. This is the so-called cytokine storm, which is a harbinger for the severe stage of SARS-CoV-2, depicted on the right side of the graph. These cytokines, in turn, attract multiple cells in the capillary blood vessels, such as fibroblasts, which play a central role in fibrosis. Notice here that the cytokine storm also leads to other characteristic alveolar changes, such as the thickening of the hyaline, also known as the cartilage membrane, which the authors of the paper hypothesize can be stopped by administration of the drugs mentioned below. Again, to recap, as COVID-19 progresses from early to severe stage, you start off with pneumonia, increased inflammation, you get the cytokine storm, and this leads eventually to fibrosis. So what is the optimal method of diagnosis of pulmonary fibrosis? When spirometry is performed, typically there is no baseline value. We simply just don't know if the person had a high lung capacity before, such as in athletes, and if his actual capacity now is within the low range of normal. High-resolution CT is superior to X-ray and MRI due to superior soft tissue contrast, visualization of full extent of tissue, and due to the relation of Hounsfield unit, range, and fibrosis. When one talks about the extent of pulmonary fibrosis, several questions arise. Patients present in different stages of the disease. Is the extent of infection, for instance as a percentage of total lung volume, a good predictive measure for all these stages? Can AI aid us in measuring the extent of fibrosis and predicting the functional prognosis? We'll go into that in the next slides. Here we see a case of a 55-year-old male with pathologically confirmed idiopathic pulmonary fibrosis, which is the most common form of interstitial lung disease of unknown etiology that results in fibrosis. Over time, the scarring gets worse and worse, and it becomes more difficult for the patient to breathe. In red, we see here a diffuse hyperdense area that might as well be fibrosis, but keep in mind that only histology can confirm the diagnosis. So here is another case of a 50-year-old male with a history of mediastinal irradiation for Hodgkin's disease 6 years earlier. This is a case of radiation-induced pulmonary fibrosis. So what are the differences between IPF, radiation-induced pulmonary fibrosis, and SARS-CoV-2 related fibrosis? In interstitial lung diseases such as IPF, scarring is progressive. That is, it increases over time, gradually affecting the patient's lung function. Post-ARDS fibrosis is typically not progressive, meaning that scarring does not continue over time, although it can be severe and limiting in some cases. Currently, we simply just don't know how the pulmonary fibrosis related to COVID-19 progresses over time. So how are we able to measure the extent of infection and potential future fibrosis on CT? As we see in this image on the left, the white represents the right lung, the green the left lung. On the right image, only the area of active infection has been annotated. A part of this area may progress to fibrosis. If we measure the infection volume and divide it by the total lung volume, we get a good sense of the extent of disease, which could also potentially give a good measure for the extent of fibrosis. Luckily, artificial intelligence might also help us out in this. For instance, if we want to automatically do the task of fibrosis detection and prediction on future CT scans. For this, we will need to have a lot of labeled and annotated cases by expert radiologists to train the algorithm, typically over 500 cases. Ideally, of course, we need also pathologic confirmation, but this is sometimes difficult to obtain. Especially interesting would be if we would let a group of expert radiologists define exactly which region of the infection mask they believe is at high risk for developing fibrosis, and to train an AI algorithm that can make predictions on non-labeled CT images. This study by Humphreys et al. In the European Respiratory Journal gives you a good indication of how well artificial intelligence can perform in the detection of idiopathic pulmonary fibrosis cases. Data-driven texture analysis (DTA) is a machine learning method capable of automatic detection and quantification of lung fibrosis on HRCT. It is trained to discriminate fibrosis using radiologist-identified image regions demonstrating normal lung parenchyma and usual interstitial pneumonia patterns. Exemplar regions labeled as reticulation, honeycombing, or traction bronchiectasis were used to define the fibrosis category. The algorithm classifies local regions in axial sections as either normal lung or fibrosis in a sliding window fashion over the lung fields. So what happens, you start with the first voxel in the left upper corner and you slide through the entire lung field. And every single voxel is identified as fibrosis or normal lung. The DTA fibrosis score is computed as the percentage of the total number of window regions classified as fibrosis. In this image, we see two transversal CT slides from a 66-year-old female on the left. On the left, you see the unenhanced HRCT images. On the right, you see the regions classified as fibrosis in red by the data-driven texture analysis algorithm. As you see, it does not visually perform very well, but that is why we need to give the artificial intelligence algorithms larger amounts of data to learn from. Unfortunately, imaging cannot tell us accurately what is fibrosis and what is pneumonia. We only know this when the pneumonia recedes, and ideally we need histologic confirmation. Important questions are, what is the treatment of fibrosis, and is fibrosis at a certain point irreversible? If we look at IPF, in the US, Europe, and many other countries, there are two drugs that are approved for its treatment. Nintedanib, which is a tyrosine kinase inhibitor, and pirfenidone, which is an immune suppressant. Both these drugs can, in compassionate use, be used for the treatment of fibrosis in COVID-19. A second point that can be made is that antiviral therapy in the early phase may limit the cytokine storm, which in turn may prevent pulmonary fibrosis in select patient populations. Secondly, is fibrosis reversible in COVID-19? We still do not have long enough follow-up time to say this for SARS-CoV-2 or COVID-19, but pulmonary interstitial damage and functional decline caused by SARS-CoV-1 mostly recovered if we are to believe a 15-year follow-up study published in February 2020 in Nature Bone Research, with a greater extent of recovery within 2 years after rehabilitation. In this study, the pulmonary CT scans of the 71 SARS patients showed that 27 patients exhibited ground glass opacities or cord-like consolidations during the 15-year follow-up. 2 patients had no abnormalities on their pulmonary CT scan in 2003, but ground glass-like changes were observed in both 2004 and 2007. On the y-axis is presented the percentage lung injury on CT. On the x-axis, the number of years. So what are the take-home messages? First take-home message. High-resolution CT is the best imaging modality to assess the extent and severity of pulmonary fibrosis. Artificial intelligence-based models may aid herein and could be based on the percentage of inflammation of the total lung volume. Early treatment of inflammation in immunocompetent patients can prevent pulmonary fibrosis. Follow-up studies are needed to assess the functional prognosis and reversibility of post-COVID-19 pulmonary fibrosis. I hope you liked my video. If you did, please share and like it. Thank you very much.